that he's not sure why it hasn't achieved more attention, because it is a medical malpractice thing that should be at the top of everybody's mind. And on that question list, they present to you what factors actually cause this. How will you prevent this from occurring with my daughter? And how will you treat this? And finally, how many times have you been sued? And so as you ponder this, and you think about, gosh, this is an interrogation-based analysis of my technique, you consider some thoughts of what your training has been, you consider some of the literature, you consider how you do your technique, and you consider, perhaps I will do something either different or similarly to what I've done thus far. And so what factors are exactly responsible for the one-sided technique? Now, we acknowledge that they occur in up to 8% of the time. It's something that we have seen on our labor floors, sometimes on a nightly basis. And when it occurs, we think about the different reasons for it occurring. Now, we always start on the distal end of the needle. We say, did you see the patient when she was even walking to the bed? She was sort of limping on one side, so, maybe there's something wrong with that side of her back or her leg, or did you see how she was sitting? She was slightly tilted, or you can always think of some reason to sort of blame the patient for this existence of this block. You can also think about the equipment. You think about, gosh, I wish my hospital administrators would have given me those new catheters that seem to just be placed perfectly, or new different needles. I hate this kit, and I was trained on another kit. I wasn't wearing my lucky underwear today. All these things about equipment that we can consider. We also think about destiny, theology, divinity. When things go bad, it's God did this to you. I don't know why he has it out for you. Genesis did say, go forth, bring forward your children in pain, and this at least makes you half comfortable, so you can understand what God provides and what God takes away. These are all great theologic arguments to use when this thing happens to you. And then finally, there's that look at the proximal end of the needle. And unfortunately, this is one place that we should spend just a fraction more time, rather than the 0.1% which we might ascribe to it as being reasons for this one-sided blockade. Now, of course, when we consider the epidural space, we recognize that it is a space that's filled with a lot of different things. Nervous tissue, veins, fatty tissue, and we recognize as we approach the ligament flavum and we enter into the epidural space and we start filling it, that it is initially a discontinuous space, a space that is segmented, and a potential space. It's something that we are trying to create, trying to push local anesthetic around to the anterior and posterior side so it circumvents and bathes all the nerves on all sides. But we also recognize that as we are increasing that pressure, as we are increasing that volume, that some of that volume, local anesthetic and even saline, goes out. And so perhaps it won't circumnavigate the whole entire epidural space. We also recognize that there could be bands. For example, these have been demonstrated in by various people, where they say that maybe there's some connective tissue banding that exists on a longitudinal track that sort of shepherds local anesthetic to one side versus the other. Now, these are very difficult to sort of assess, in part because the mechanisms by which we have to look at the epidural space are difficult to see. And when we do try to employ them, we sometimes really antagonize or disrupt the epidural space so that we can't really look at it. For example, when we do anatomic dissections, these are very messy and we distort things as we look at things. If we inject resin, perhaps you distort the space as you go along. And that's the same with contrast as well as other things. Even cryomicrotomy, which is Quinn Hogan's technique, where they take a fresh cadaver, immediately freeze dry it, take microcomb sections through it. Even the freezing process might change the epidural space in some way, in that we can't study it very well. So we are left then with an appreciation of the epidural space as it is and as it is under various disease processes. And we recognize that 70% of Americans have back pain, 50% oftentimes undergo some therapy that includes epidural steroids or anything else. And we recognize that in doing so, that sometimes pain is unilateral, sometimes even the epidural steroids that we inject in there don't really cover the area that we are concerned about. And so the epidural space does change over the course of time, and sometimes we're only just testing that for the first time when we're inserting an epidural labor analgesic. Acknowledging those anatomy changes and things that occur, we do have to pose the question of how can we prevent this? And is it something that is preventable? When we assess the epidural space, we pose that question of, does imaging help? Now, for those ultrasound advocates, you know, these are like people that are on late night television commercials. They really feel like epidurals and ultrasounds, ultrasound devices solve everything. I mean, it's like if you are doing bad epidural placements, put the ultrasound on there, presto, you have perfect epidurals. You have bad marriage, ultrasound tech pro, presto, everything works. I mean, and so you have to take some of these studies with a grain of salt, in part because they're done with very experienced individuals. They usually have one ultrasonographer who is incredibly experienced, and also they have individuals that are doing the technique that are experienced as well. But it does bring up this thinking that perhaps plain films and CTs and MRIs can give us some meaningful information. And in fact, if a patient were to tell me, gosh, I have some films of my back, I've had back problems before, do you want me to bring them in? I say absolutely. In part because there may be something that I can witness on those films. Perhaps I will see something, and I'm not in any way gifted with radiology reading, but at least there might be something pre-circled where I can say, oh yes, certainly, this is something very concerning. But it also can indicate where there might be some bony artifact, there might be Harrington rods that even the patient doesn't realize, and those sorts of conversations can at least set the expectations, so that if something were to not work as well as you'd like, that you can at least engage in that and maybe find a reason for that. But what is interesting, such as with scoliosis, is when you dose that catheter, there's going to be less resistance on the open side, and it is true that you might get more of a one-side block in people with scoliosis, just because of the fact that more open, less resistant side accepts more of your local anesthetic. So how about the needle sort of placement in terms of the bevel of the needle? Does it actually make a difference in terms of commanding a bilateral or one-sided block? And I must turn to the attention to Sue and Jane Hufnagel at Temple University. Excellent study where they took 160 individuals, randomized them, these are all pregnant women, randomized them to 40 in each group to either have their epidural placed with the orifice of the needle facing left, cephalad, right, or caudad. And what they found was in terms of one-sided blocks, this was least when the orientation of the needle was cephalad. This also followed suit in terms of inadequacy of block, and then overall comfort was higher in the group that had that cephalad orientation. So you can see there is some benefit to the orientations. And you know, where this comes into play, because I think probably most of us do approach the space with the cephalad orientation, or at least thread the catheter in that orientation. I think where this might come into play is where you do get that difficulty. We talked about when you're trying to thread that catheter, you are convinced that you're in the epidural space, and that catheter just isn't sliding in. And so you load it up with a lot of saline, you mention some incantations, you try everything, doesn't work. Many of us, I mean, how many of us would slightly deviate the needle just a little bit, maybe pitch it off to one side? Do I have some affirmations there? Okay. So in doing so, you might actually be creating a situation where you might cause a one-sided epidural. And to provide evidence for that, there's a couple studies, a nice one by Dory, which they entered with the cephalad orientation for these knee scope patients. they rotated intentionally to the affected operative side. And what they found was, in terms of their block, there was, on insertion of the catheter, greater paresthesias on the operative side, but greater sensory, also greater motor blockade on the operative side. And overall, because they had to use less anesthetic, they had less urinary retention, but similar analgesia. I actually use this process when I'm down in the main operating theater. I do tend to rotate my epidural catheters off to the operative side, because nothing is worse than blocking the non-operative side, right? And we've all had that. But Borghi also demonstrated this with hip operations as well. Similar situation, enters in the cephalite orientation, turns towards the operative side, and what they demonstrated was faster, more intense blockade on the operative side that you did the rotation to, greater sensory blockade on this as well. So both these studies taken together suggest that even those small decrements of rotation, once we approach the epidural space, may have some influence in terms of bilaterality or unilaterality of our epidural blockade. Now, how about the technique? We have heard CSEs, we've heard a little bit about dural puncture epidurals, as well as standard epidurals, and does the technique matter, and does it make a difference? Well, we've heard through the course of the meeting that with combined spinal epidurals, we have lower failure rates for those catheters, especially at time of cesarean delivery. When you're dosing it up, you want the most maximal bilateral block. And this is probably in part because of where the medication is going, but you also heard an allusion to maybe that conduit that is between the epidural space and the spinal space maybe having some function. So with a combined spinal epidural, we're coming in, we're inserting that spinal needle, we're depositing some local anesthetic, sometimes with opioids, we're pulling that needle out and we're watching the process. But we also, in that process, must acknowledge that if we did not get CSF, should we go ahead and dose? And the response to that is found in John Thomas's study, where they were using 27-gauge combined spinal epidurals, is they said if you you were attempting to do a CSE and you did not get spinal fluid, but you went ahead and threaded the catheter and dosed it up and anticipated that it would work, well, in 22% of those cases, the epidural catheter failed. Whereas if you did get CSF, and everything worked fine at time of technique, there is still a failure rate, but it's significantly lower than if you had no CSE. Suggesting that our confirmation that we're in the right location is one value of a combined spinal epidural. But the other value of the combined spinal epidural is that conduit that you create. And that's the idea behind what we call and what we term the dural puncture epidural. And essentially what that means is that you are taking that same combination of needles, you're putting that needle through into the dural sac, but you're not dosing any of the spinal medications. You're just creating that conduit. And then you go ahead, thread the catheter, you dose the catheter, and with that pressure and with that dosing, you actually translocate some of that medication into the spinal space. Now, does this actually work? Is it something that's effective? Well, Suzuki was the one who gave me the original idea, and that was in knee arthroscopy patients. They were using a 26-gauge needle, and that was with surgical anesthesia. I thought the same could be true with analgesia, and specifically labor analgesia. We designed a study. John Thomas was one of our fellows. He finished up before he was able to commence the study. He took it down to Wake Forest, where they used 27-gauge needles for their combined spinal epidurals, and that showed no effect. I thought it might be a phenomenon related to the size of the spinal needle, so I did it again with a 25-gauge needle, and that's our typical needle that we use. And basically, just by the dural puncture epidural technique, so you're not placing any medications directly into the spinal space like a CSE, but you're just causing that dural puncture, threading the epidural catheter, dosing the catheter. We have better bilateral spread, better sacral spread, faster onset, and overall better function of our technique. So that small hole really makes a large difference. Okay? And it's one way that you can create a bilateral analgesic episode. And I think it's actually a superior way because you don't get the fetal bradycardias that you might get out of a combined spinal epidural, and you get to test the catheter from the get-go. So in people of high BMI, not only confirm that you're most likely in this appropriate space, but you get to test the epidural catheter at the same time. Okay. So how about multi-port versus uniport catheters? And there has been some science and some looks at this. We did a systemic review of epidural catheters. I know this is very small print, so I'll just enlarge it to the 3 studies that looked at this specific question. And essentially, what has been demonstrated with the older nylon catheters, at least, is that multi-port catheters will offer you more bilateral spread, better overall analgesia than uniport catheters. Now, I must say that the new stainless steel impregnated spiral wound catheters have not been studied robustly in this way. What we have determined thus far is that they do offer sort of better bilateral coverage, even with uniport orientations. So a study needs to be done. But certainly for the stiffer nylon catheters of old, and some people still use them, it is possible that perhaps they migrated off to one location. That location offered a one-sided block more than a bilateral block. How about catheter insertion depth? Does it matter? And how far do we usually go? 3, 5, 7? I've seen some people even go 10 centimeters into the space. And when we think about this, one of the studies that was done not too long ago was a retrospective study looking at multiple different providers having different practices, and they were just trying to see if there are any of these practices that resulted in more one-sided blocks. And what they determined was, by and large, younger patients having their epidural space engaged at a lower inner space with more catheters were those individuals that have more one-sided blockades. And indeed, this is our population on labor and delivery, younger, lower inner spaces. And then that question about catheters is certainly something that we can think about. And Jake Balin took a look at this in a prospective manner. He randomized individuals to have either the catheters placed in 3, 5, or 7 centimeter increments. And what we found was, in addition to just more intravascular catheters when you place the catheter in further, in terms of one-sidedness or pain that was exhibited because of incomplete analgesia, this was highest in both the 7 centimeter group, mostly because of unilateral natures of the block, but also in the 3 centimeter group, and that was because no block. So the catheter fell out at a certain point in time and then just didn't offer any additional analgesia. And this has been confirmed by Afshan. They did a similar study. This is in non-pregnant women, but they did fluoroscopy on all the epidural placements as well as contrast confirmation of the epidural. And what they found was that as you enter the catheter more, so you're going from 5 to 7 centimeters, you get more unilateral blocks. So certainly the amount of catheter we place in the space makes a difference. So if you do take some of these steps and you don't get that, one-sided block, that's great. But even if you take all these steps and you're resulted with a one-sided analgesia that the patient's uncomfortable with, how do you exactly respond to this? What sort of treatments do you have in your armamentarium? Well, one thing to consider is what your initial dose is. And to this, I offer the evidence of Francois Christian's from Brussels. And basically what they did was they took the same 20 milligrams of bupivacaine, but they divided it into 3 different sort of solutions. Either a very concentrated 4 milliliters, a less concentrated 10 milliliters, or an even more dilute 20 milliliters. And what they found in terms of number of individuals becoming comfortable is it was greatest when you use very dilute concentrations but high volume. The epidural space is incredibly responsive to volume. And as we recruit the different spaces in the epidural areas, we need to acknowledge that the more fluid that we push in there that can spread around will probably invoke a block that we're more satisfied with, a block that the patient is definitely more satisfied with. But let's say you still have that one-sided block. You've only placed the catheter in 5 centimeters. How are you going to treat this? And the question that we pose is, are you going to pull back that catheter and dose it, or are you just going to dose it? Jake Bailyn also studied this, and basically he took a group of individuals, he consented them beforehand. He said, if you have a one-sided block, we'd like to do one of two different options. We'd like to either just dose you with more local anesthetics, or we might pull the catheter back 1 centimeters and then dose the anesthetic or your epidural. And what do you think they found? What they found was that roughly 25% of individuals did not become comfortable with their management, but that there was an equivalent number of people that became comfortable with the two different methods. What that suggests is at least you probably don't need to go through all the shenanigans of taking that tegaderm, pulling it out sterilely, putting it back in tegaderm, taping it up, and then just watching what occurs. What you can probably do first is just give that first initial volume bolus and then see what happens. Now what's kind of interesting is Jake did do the second intervention, meaning that in that group of patients where he pulled the catheter back and dosed, if that was still one-sided block, he just gave more local anesthetic. In the other group, where he initially just gave the bolus, his second approach was to pull the catheter back and then give another bolus. Now, what is fascinating to me, and I've asked Jake about this in person and in public forums, is he got everybody comfortable. And as we all know, I mean, there are people that have one-sided block. They will always have a one-sided block. I mean, you can dissect out their whole epidural space and just so that they have no epidural space, and they would still have a one-sided block. But he said, well, that's what we found in the study, and I know Jake to be a very honest and upright guy, and I agree with him. But I said, Jake, but tell me this, if you think that volume only will work, then why not just use volume only as your second intervention and just see if that would have solved everything without even manipulating the catheter? And he said, that's a good idea. I should have done that, but if we didn't, and so there you have it. But it's certainly an idea that someone can study in terms of what can work and if volume only will solve most of the crises in terms of one-sided block. So in terms of one-sided block, what we do know is a very big and large hidden picture. It's something that we think about. It's something that we need to study more. I think with more sophisticated imaging devices, perhaps we'll get a better understanding of what oftentimes causes this. But what we do know is compelling, and it's something that we can use to change our practice. And the things that we can use at this point is, if imaging is available, then use it. Certainly as we get more facile with ultrasound technologies, perhaps those will help us, at least identify the midline and perhaps give us a better block. We need to orient our bevel cephalad, so if the patient's in a lateral position, we still need to accompany them by moving that bevel cephalad. We should consider at times adding a dural puncture. And if someone had a one-sided epidural blockade, they've been uncomfortable, you've decided to replace that catheter, I would encourage you to use a dural puncture or a combined spinal epidural technique, because you want to offer some different avenue by which local anesthetics and opioids can get to and provide analgesia. Also, we need to limit the catheter insertion depth, so 5 centimeters is usually the sweet spot that's been demonstrated by different studies. Consider use of multi-orifice catheters, except for the newer catheters that still needs to be evaluated. As I mentioned, the newer catheters, uniport and multiport, seem to function very, very similarly. We need to consider giving high volumes when we deliver our blockades, as well as rescues from one-sided blockade, and considering giving the top off before going through all the problems of pulling back the catheter and dosing again. So hopefully you can use all these different elements. And you can see it worked with this particular patient that we had, our index patient. And in fact, they scratched out that last different element, and now they want you to do the epidural for the knee replacement. That's going to be happening for the grandmother. So thank you for your attention. Thank you so much for coming. Certainly, we invite you back to Sol Shnider next year.